Hey, good afternoon, everybody. Thanks for joining us. Looks like people are joining on pretty much. We have 14 of the 30 folks who registered. As a brief introduction, my name is Peter Antevi, and I'm one of the medical directors here in Broward County. If you're on your computer and on your screen in front of you, you'll see the list of the Greater Broward EMS Medical Directors Association. And the folks here who are listed, who have a red dot next to them, are going to be on this call today. So it's exciting to see that we have such great involvement, which we've had for the last couple of years in EMS. And also exciting today is that we have a significant number of folks who are really in the hospital community who are interested in today's topic. So I'm hoping for a great conversation. Just a quick preview. The whole purpose of what we're doing today is really just start to get a roundtable discussion going on freestanding EDs in Broward County. I mean, it goes without saying that these are items that are going to be coming up. They're springing up pretty much in multiple locations, and wanted to have EMS at the table with the folks who are starting these entities so that we can really move forward in a manner that's cohesive, rather than anyone developing their own protocol and so forth. Just a little bit about our entity. This is basically our website. We have all of our protocols, which are accessible to the lay public. They can be downloaded as a PDF, or you can search the document as well, and you can find that at www.gbemda.com. So if you want to know what our protocols are, what we do, you can find them there. We have created a Dropbox folder that's available to anyone, and you'll get this link at the end of the webinar. We'll send this link to you. But in the folder, we have basically all the documents that we've been kind of collecting, so that we can develop these protocols and policies and so forth. And so there's a URL if you want to write it down, but I'll just send it to you via email. Just some housekeeping stuff. Most of because this is a webinar format, the attendees are typically on mute. I made all the medical directors panelists so that they can kind of mute and unmute themselves, but would really like input from everyone on the webinar. So if you look at your control panel, there's a small little hand there, and if you want to say something, just click the button and I'll see it, and then I'll kind of bring you into the conversation. Alternatively, there's a question bar. You can just type in a question, and then I can moderate that question for you. Throughout the presentation, we've created a couple of just poll questions just to see where everyone is in their agencies and so forth, just to try and keep it interactive. We are recording this presentation so we can make it available to others who are not able to attend as well. So without any further ado, I'd like to bring in Dr. Tony Gandia. Dr. Gandia has been in the Broward County EMS service really for many years. Has been an integral part. Currently is with Margate and Coconut Creek as their EMS medical director. More importantly, is the medical director for the freestanding ER in Mount Sinai, which sits in Aventura. And so Tony really has a lot of knowledge at the state level, and has been instrumental in really getting the knowledge out to us as EMS medical directors. So without further ado, Dr. Gandia, I'm going to give you the floor so you can give us an introduction into freestanding emergency departments.
Great. Thank you very much, Peter. Again, thanks everyone for joining us today. And I got to, as always, commend Peter for always doing a great job putting all these webinars and everything that he does, really putting us together that we can all talk and share our thoughts, headaches, and protocols, of course. I think I should maybe just talk quickly about the freestanding DD, maybe just a quick history. And I sent a letter to our organization when we first talked about that. And, you know, the freestanding DD really has been around for about 35 years. They started out in Florida about 12, 15 years ago, really with two up in the middle of the state that opened up as freestanding ERs. And at that point, you know, sort of ACA and the regulatory folks put a moratorium on the freestanding, so they kind of figured out really what they were all about. Subsequent to that, Mount Sinai came on board about 8 years ago, being the third one in the state. And by that time, ACA and the regulatory folks were quite happy with freestandings, because those two that opened up really, first of all, did a great job. They were sort of pilots for us in the state. And subsequently, we have some really very decent regulations and statutes within the state that govern the freestanding emergency departments. And most importantly, I think to us as a EMS community, and certainly as an emergency medicine community, the regulations within the state is that a freestanding emergency department needs to function like any other community emergency department within the state, which really includes many things. It certainly includes the architectural stuff that has to be pretty much built like any other ER, meeting all those requirements. It has to have the auxiliary staff, it has to have the CT, the lab, and all that, in-house and within their framework. It has to cover the EMTALA obligations of like any other ER within the state. And also, most importantly, I think, is that it clearly needs to be connected to a hospital, a main hospital. And I think that brings up a lot of very important points. Most importantly to me, both as an EMS medical director and emergency physician, is that the on-call folks for the freestanding emergency department are the same folks that are on call for the main ED during that 24-hour period, or whatever they do, whatever they cover. But for instance, if I needed an orthopedic specialist for a case at my freestanding ED, it'd be the same orthopedic specialist that's on call for the main hospital. Fortunate for me, I have 14 on-call specialists at my freestanding that, truthfully, I never had at bigger places, because the same folks that are on call at Sinai are the same ones that are on call for my freestanding as well. So I think that's kind of a big deal for us, both on the emergency medicine side and clearly on the EMS side. So really, when we think about freestanding, certainly in our state, we really should think of them as, okay, there's another emergency department that's available, to us, both as patients and as EMS providers. We really with nothing less than any other community ER that we would go to. So that's where I think we have to start with our mindset that the freestandings, by statute, by law, have to have the same thing that any other community hospital has. Obviously, the other stuff, such as trauma services, cardiac services, stroke services, I mean that's clearly left for the main hospital, and just like any other hospital who doesn't supply that, those patients are either transferred, and we can talk about that later on. So my basic premise for freestandings is basically that, listen, they're like any other ER that should be in our community. With that being said, wearing my EMS hat, I mean, there's clearly, just to give you an idea, we were the third one 8 years ago in the state. There are now 16 freestanding emergency departments. You see 14 on the graph here, but 2 hospitals have 2 freestanding. So it's really 14 plus 2, because again, 2 hospitals have 2, so really a total of 16. This data is from ACA, which really I think about 5 years ago, I said, well, you know what? If we're a freestanding community, maybe we should try to get a voice within the state. So I was fortunate enough to form a committee that's co-sponsored by the Florida College of Emergency Physicians and the Florida Hospital Association. And, we kind of meet probably on a quarterly basis and, kind of gather our data, our headaches, our issues, and so forth. And it's really a wonderful organization, because everyone there really, especially for the new folks, and you see Memorial Hospital in Jacksonville, they just recently opened up, and we all really share a lot of sort of the aches and pains and issues, and it's really a nice collaboration. We just recently had a meeting about a couple of weeks ago, and we'll talk a little bit about that as well. But anyway, the data that's sitting in front of us really is, I believe, from like March of 13 to March of 14, and this is the ACA data for freestandings. Interestingly enough, when we first started our committee, the freestanding census and data was kind of bundled in with the main hospital data, so we really couldn't pull out the data for freestanding, say, well, how many patients were seen here and there, because it was really, when they reported the emergency department visits, they bundled both of those in. We were able to convince ACA, and they were certainly amenable to it, to maybe split them out. Let's get the data for the freestandings and also the data for the main hospital kind of separate, and that's what we see here. And as you well see, every freestanding is very busy. You have freestandings seeing patients, that have been established for a year or two already, seeing patients anywhere from 50 to 100 patients. There's one that sees close to 150 patients a day, which is a pretty decent number. Also, the last column you see the percentage of patients seen by that hospital organization. You can see how much the freestanding sees from that hospital organization. Interestingly enough, when some folks put up the freestandings with the hospital, their concern was, you know what, are we going to take away patients from our main hospital? And almost all of them have found that has not been the case at all. That these freestandings really stand alone with their census and so forth. But anyway, talking about our issues on the EMS side, I think again, and obviously we're going to have a fair discussion, hopefully. I think again we have to look at these as regular community-based emergency departments. I think for our purposes, I think what's very important is what the transport protocols are going to be for the patients that are admitted and then subsequently need to go to their individual hospitals. How do they do that transport? I don't think that many of the EMS folks want to go back there and again transport someone else to the main hospital. It becomes an issue, one, of manpower, and also as important, it becomes an issue with reimbursement of those transports, etc. Peter's kind enough to put up a lot of those numbers, and you can really see, and I got it. You can pick that up when we send this data out. I mean, you can really see the breakdown that we have in self-paid and all that. Most recently, some of the ACA data came out, which we had a presentation in our committee from ACA, which was kind of interesting. They gave us a similar breakdown from second quarter in 2010 to second quarter in 2014, and really the payer mix stayed pretty much about the same. The self-pay, interestingly enough, went from about 20% to about 17%. The Medicare stayed pretty steady, about 18%. Medicaid kind of went up from 26 to 28%. The commercial insurances stayed pretty normal, about 32%. And then the other, whatever that is, went from 4.2 to about 5.2. So the payer mix is staying pretty much consistent year to year. I said these comparisons were from 2010 to 2014, and it seemed pretty close equally. Interesting enough, the age distribution also, this is from the 12-month data from ACA, so pretty much a year. It shows that under 18 was about 25%, which is kind of interesting. The 45 to 65-year-olds were about 20%, greater than 65 were about 15%, and the 18 to 44-year-old was about 40%. So very interesting demographics. Seeing a fair amount of pediatrics, I think a lot of it has to do with access. And believe it or not, I often see folks that get to the pediatrician's office, they see that it's way too crowded and come to our freestanding because they know that they're in, they're out. The discharge status, interesting enough, for that time period, about 96-97% of patients ultimately got discharged home, which really left about 3% at admission. But although and that goes to patients going somewhere else, whether it be to the main hospital or to another hospital facility, etc. So the bottom line is that really as a whole, we've probably seen close to 300,000 patients with the 16 freestanding emergency department. As important, that has yet to be an ACA complaint of a patient or anything like that. And thus far, the EMS systems that are having a relationship with these facilities seem want to be pretty happy with them. I mean, no question that the crews clearly love coming. They get in and out. And I think as important is that the EMS community has really maintained a very good relationship and close relationship and really a close eye on these facilities as they pop up among our state. I think I'll leave it there because I'm sure there's plenty of questions and we can just springboard to further discussion from the questions that we get or the discussions. Thank you so much. And Peter, again, thank you so much for putting all this together for us.
Awesome. Thanks, Tony. I appreciate it. I have a quick question. Um, for how long have you had your freestanding ED in Aventura? How many?
8 years. On the 27th of February or January, I think it was 8 years.
And as far as the traffic is concerned, the EMS traffic that brings in, what type of patients do you see them bringing to you?
You know what? It seems to be the acuity seems to increase a little bit again as they get to know us better. We had an interesting time down in Miami-Dade. That, as always, is an interesting place to be. South of the border, as I say. So it took a few years actually for them to even to start transporting to us. But we really get really the realm. I mean, obviously, like I said, none of those alerts come there. But we get patients that are either pneumonia, CHF, nothing that cardiac-wise, no, really normal with active chest pains or anything like that. We get a lot of the NVAs. We're right across the street from the mall, so we get a lot of the bumps and bruises and falls and ankles and knees and so forth, coming from across the mall. Our traffic clearly has increased by EMS with the patients that want to come to our facility, and that's, I think, something that we can talk about later. How we slowly kind of move EMS patients to those facilities, because I think as a public service, to our community, those patients that really want to go there because their physicians are within that hospital organization and so forth, it's not worth the aggravation and the argument. And truthfully, if they're, fairly stable, to go to those facilities is way easier. And we as medical directors and the people at HR don't get all the complaints about not being transported to those facilities. So we're getting more and more of those folks coming to us. So really, and again, most freestandings admit about 10 to 12 to 15% of their patients. So really, most of those patients, even though they come by EMS as opposed to a lot of the main EDs, most of those are still being discharged.
Okay. Well, let me kind of just delve in a little further. That was good. I think what a lot of us, at least on the EMS side, are not, maybe the word is not worried about, but at least want to be aware of, are if a patient comes to your freestanding, Tony, in Aventura, and they're, they live locally to that area in Aventura, and they have to be admitted. Are they given the choice of what hospital to go to, or is it an automatic, for example, that they're going to go to Sinai?
No, absolutely. You know what, Peter? It's very interesting because, as you well know, we're a mile away from another facility,
Sure.
and again, the folks in the Aventura area, there's a fair geriatric population and so forth who clearly say, listen, I go here, my spouse can't make it to the hospital, etc. So we transport them to wherever they want to go. We have a great relationship with Joe DiMaggio, and they take all our kids out of there. But truthfully, if someone says, my doctors are there, I want to be transported there, we do send them there. What's interesting now, even the local docs are sending their patients to come to our ER for their initial workup and then request that they be transported to the other facility because they know, again, as it stands now, we really get people, our throughput time are very, very short. So they get the initial workup and then they go to the other facility. So they clearly have a choice.
Okay, good.
If they want to go to the other facility, they clearly transport it. If not, they do get admitted to Mount Sinai.
So let me follow that up with, if they come in via EMS and then they have to be transported out. So it's a two-part question. A, are you transporting them with 911 or a private? And I think I know the answer, but if you can answer that one. And then if they don't go to Mount Sinai, the sister hospital, and they go to Aventura, are they given a second bill? And that's it, which is a question a lot of people have been asking.
Well, that's a good question. I can answer you the first, and that is, and truthfully, even before I came on board with Mount Sinai, wearing my EMS hat, I was very clear that we did not want to call 911 to transport these patients to the main hospital. And basically, and I think a lot of the the freestandings have followed suit, and that is that they have their own private EMS contractor sitting there within the facility to make those transports. So they get transported over by the private ambulance. Truthfully, I cannot answer the bill on their ambulance bill. One of the things that unfortunately that we find is that some of the hospitals, and I can talk for the Aventura folks, and that is many times initially we were able to transport those patients right to the appropriate room, like we do from our freestanding, and that is that they go right to whatever room they go, and many go right to the OR for the simple appies and hip, and things like that. But unfortunately, the trend has been most recently that they end up going to the other facilities ER, I guess till they maybe get seen, reevaluated, or get a bed situated for them. But I really can't answer about the second ambulance bill, or even if there is an ambulance bill, because I know we have a contractual relationship with the private ambulance to do those transports.
Got it. Okay. That was okay. And maybe somebody else on the call can help us with that answer. I have a question coming in from Cheryl Rashkin, and Cheryl wants to know, what about Medcom? Is there going to be a Medcom attachment to all these freestandings?
Well, we have a Medcom attachment with for Miami-Dade, and actually, Hollandale, who transports to us across county lines, they pretty much call directly into our landline. But we do have a Medcom that's available there and is used.
Okay, very good. Maybe I can bring in. I see that Chief Mark Ellis from Hallandale Beach is on the line. Mark, would you mind unmuting yourself and because since you have the experience. Okay, there you are. Mark, you there?
I'm here.
Hey, Mark. Thanks.
I'm here. Do you hear me?
Yeah, we hear you. Are you able to comment on what your experience has been since in Broward County you've been working with Mount Sinai for quite a while from the EMS perspective?
Sure. Our relationship goes back probably half a decade or more with the city, and this predates my coming to the city of Hallandale Beach, so there's some things that went on before I ever got here, so I can speak to some of that and more as to what happened after I arrived. I know when Mount Sinai first opened, I think the relationship initially was a little trepidatious, probably like a lot of the agencies are having right now about, who are these people, how's this going to work, things like that. But they went ahead and began taking patients there, but from when I look back at the original policies, a lot of the patients were very much the minor patients, and they were only patients that were specifically requesting to go to that facility. Now, over the years, that has since changed, and we've actually gotten to the point now where we take basically any patient that is not an alert, a stroke alert, a cardiac alert, a trauma alert, that type of thing, to Mount Sinai. That we've realized over the years that they can handle basically anything that they're classified for, so we've taken our limitations away from what we transport there. And our guys will often comment about how that their facility is kind of like concierge medicine, because you can go in there and get treated so quickly and be seen so quickly and not have to sit and wait, in 30-minute, lines, for a patient, we're having to wait at triage desks, and there you're seen right away, and you're in and out significantly faster than most other facilities. So we've enjoyed a really good relationship with them.
Very good. And so as far as the EMS crews themselves, you think that they kind of tend to gravitate towards that type of facility in your estimation?
I don't think that they gravitate toward them. I think that they are a tool in their work box. They know they're there. We do have a fair number of patients that are requesting to go there now, especially if they've been prior patients. They want to go back there. We've got 4 hospitals to choose from within our city, so they're one of the 4 that we have to choose from. And based upon, most of my guys are choosing facilities based upon patient request. So, anyone who requests to go there that does not meet one of the alert criteria is transported there and allowed to go there.
All right, awesome. Well, let me bring in Wayne. Dr. Lee, can you unmute yourself? Because I think that when we initially had the discussion regarding, do we develop a protocol, A, or B, do we just make it a policy for each individual agency? I think, Wayne, that you were of the opinion of, to kind of keep it simple. Can you kind of give us your input on how you think EMS should determine destination?
Well, I like what Mark said. I thought that was pretty good. We don't, by, sorting out the alert patients. I think once you get into, you go, and that's actually sounded like a pretty good methodology. I had some early involvement with the freestanding EDs, and I went up to Halifax where they had some of the first in the country, and looked at those very carefully, and so on and so forth. And so I sort of had the feeling, as Tony has said, that for all practical purposes, they're just like any other emergency department. But at the same time, all emergency departments aren't created equal. So certainly there are, as we know, there are hospitals that can't handle, this alert or that alert, whatever. So I kind of like that methodology. I do not like, making it, putting the burden on the paramedics where it is, it is very, very gray in their mind. I think we have to be fairly specific, make it, it's this or it's that. As I always say, you can't write rules or replace judgment, so you have to allow for that. But I would say that I don't think we should get into I shouldn't say exotic, but a special set of protocols for freestanding EDs. No more than what we do already. Is if we had a stroke alert, we wouldn't be taking them to a hospital that that doesn't accept stroke alerts. At the same time, we don't have pediatric alerts and we don't have OB-GYN alerts, and yet the working rule is within reason. If you have a pediatric case, you take it to now in our community we take it to a place that has a pediatric ER. If you have an OB-GYN patient, you take it to a place that has OB-GYN. But that's not required. It's not technically required. There's no regulatory requirement of that. There's just a good sense. So I think we ought to do it very close to the same way. I'm done, but when you get a chance, I have a question I'd like to ask Tony.
This is Tony. A couple of things. I think both Chief Ellis and Wayne made great points. And I think one of the best points made by Wayne is that not all ERs are created equal either, even though they're called ERs. And I think that's where Mark's initial kind of concept, where he kind of slowly, and this is what I feel, if there's going to be a brand new freestanding in my catchment area with Margate and North Lauderdale, and I feel very similarly to what Mark did, wearing my EMS hat. That we start out slow, just like any other ER, just like clearly like Wayne said, and may not be all created equal. And we start slow, and we see how their capabilities are. I got to tell you that one of the things we all have to be very clear that listen, these are still ventures that hospitals are getting into, and truthfully, they really depend on these freestanding ER to be one of their sort of jewels within their hospital corporation and their marketplace. With that, most of the freestandings have enjoyed, and I as being the ER director, they enjoy the fact that a lot of the folks that are there are really the more seasoned, mature people in the ER, because again, these hospitals who are building these really want to make these work because obviously it's a big investment. It's certainly, it has a lot of political show and also within the public. So almost within my committee in the state, it seemed that almost all of them, send again most of their experience, more mature nursing staff, physician staff, auxiliary services, and so forth. For me, as a medical director, I benefited from that, and I think the EMS folks will realize that too. That that the staffing there again, it's going to be probably, high quality for sure. So
Right.
again, we need that relationship. And what's most important too is many times, us as EMS folks will recognize those folks because those are the same ones that work at the main ED.
Right.
Uh, Almost all of, I shouldn't say all of them. I think probably clear about 70-75% of the staffing on the provider side, because I have all my attendees rotate from the main ED, through at the freestanding. So everyone that works at the main ED, rotate through our ED as well, just like any other shift. So at least everyone feels the pain of the freestanding and realizes, what could be done there. Plus the familiarity with the staff, the house staff, and the medics and all that is there.
Right. Well, speaking of the main ED, I also wanted to bring in Dr. Rich Paley, who's medical director for Lauderhill and Lighthouse Point, but who also runs the show up in St. Mary's up in Palm Beach. And Rich, if you wouldn't mind just commenting, I think you have to maybe you may have to unmute yourself there. If you wouldn't mind commenting on your perspective and also the transfers that you're seeing coming into St. Mary's. Rich, it looks like you're on mute, unless he had to. I know he's. Let's see. All right. Well, while we're waiting, Rich may have had to go. There you go.
Can you hear me?
Yeah, I hear you now. Yep.
Okay. Oh, it was weird. I was on the phone, but I had to unmute it on the computer. That confused me. The technology. Yeah. St. Mary's. We don't have a freestanding ER, but there is a freestanding ER in our general neighborhood up in Palm Beach Gardens, and Palm Beach County Fire Rescue does transport to them as they would any emergency department. And I haven't run into any issues. We have gotten some transfers from them, just as we've gotten transfers from any hospital, because there are many holes in the coverage in Palm Beach County and further north. Not every hospital has full specialty coverage. So the fact that there are patients being transferred out of the freestanding to us, it doesn't make them any different than any of the full service hospitals. Mm-hmm. In fact, the ones that usually are transferred to us are strokes. I think they do. I am not sure that Palm Beach County discriminates stroke alerts or not, or at least in the past, I'm not sure if they had. Maybe going forward they will, of the freestandings versus the non-freestandings. I guess with the understanding that the freestandings can give TPA. However, I imagine in reference to the present data, that will probably change. But our experience in Palm Beach County has not been any different with freestandings than with any other emergency department. I haven't encountered any difficulty. And I think Tony mentioned that the docs who work in them tend to be more mature, and I think that has been our experience as well. I think some of it is maybe political, some of it is the fact that these are docs who've been working for many, many years and want to wind down in a slower pace.
Right.
But in any case, they tend to be the docs who are working there tend to be experienced and are comfortable working without as much backup.
Okay, well that's actually good for everyone to hear. I wanted to John Cunha before we get you to ask Tony a question. John's asking a question. John Cunha, medical director at Oakland Park. Where are the freestanding facilities going to be in Broward, and when are they coming online, and who is running them? And so, Tony,
I think I could answer some of those because some of them are tenant, and since I work at a tenant hospital, I know that I know two of them are going to be tenant. There may be more than two.
Well, there's one
is good.
Right.
One's going to be down in Davie, which I think FMC is putting one down there, aren't they?
Yep. Right. They are. We actually toured it. Very nice facility.
And I've seen the facility. Well, not that prior to it being completed, but there's a facility in Coconut Creek near the casino.
Correct.
That also looks very nice, but that one's interesting because that's going to be the parent of that is across the county line. That's at West Boca, though it's only 4 miles apart.
Interesting. Okay. And then there's actually HCA, as we all know, on the NSU campus is putting up a really nice. It's going to be a full-fledged hospital in a couple of years, but it'll be a freestanding ED at first. And go ahead.
Peter, my understanding was that they were going to turn Plantation General into the freestanding ER.
How about we get? I think we got Jerry Parklop. You're on the phone. Jerry, can you address that as far as the Plantation conversion over to a freestanding, and then the current freestanding you're building? When's that going to come online? Jerry, I unmuted you. You can, if you're there, you can speak. If not, we'll bring in who else we know that is Lee on the line? Yeah, Lee. Okay, Lee. Unmute Lee. Okay, Lee. Lee, can you hear us? Whoa. We're getting major feedback there.
Yeah. Hey, can you hear me now?
Oh, who's this, Jerry?
This is Lee.
Okay, yeah, Lee, we can hear you. Go ahead.
Hey, Peter, can you hear me now?
Who's this, Jerry?
Oh, this is Jerry. Yeah, I finally figured it out.
Okay. So Jerry first, and Lee can chime in after that. Go ahead, Jerry.
All right, sure, Peter. So the plan is, so the freestanding at Davie, there's going to be a freestanding for a number of years. Then the inpatient beds at Plantation General will then move to the new facility in Davie, and Plantation General will become a freestanding emergency department after that fact. And I'm sure Lee can talk to this, but it's probably a 5 or 6 year plan, I guess. It's nothing that's going to happen in the very near future.
So in other words, the Plantation is not going to be a freestanding until the NSU full hospital gets built.
That's my understanding.
Okay. Okay, and let me unmute Lee. You're unmuted now. You can go ahead and say that. Just wanted to say.
There really isn't anything other to add. Dr. Parkaluk stated it perfectly.
Okay. All right. Perfect. I'm gonna mute one of you guys here so that we're getting some feedback there.
Let me comment on where the freestandings are and what's coming on it. And I think as Dr. Paley said, there is one by West Boca that's going to be in between West Boca and Northwest Medical Center on 441. I think they're in Coconut Creek, and then the other one in Nob Hill and 595. Interesting enough, within my committee in the state, every time we try to find out how can you hear me? I'm sorry.
Yeah. I'm just
trying to find out from even ACA, how many are coming on board and this and that. And the only folks that have exact data is the building department folks, because they have to, the building department, they have to send in all their plans and so forth. Because remember, as I said earlier, the ER has to meet every architectural requirements as any other ER, and those are the folks that know first, even before the ACA, CON, and so forth. So I got a name from on the state level from someone who probably has a better list than even the Department of Health or even ACA and so forth.
Okay. Yeah. Well, I mean, but I think that if you can get us that list, that'd be great. But in the meantime, it sounds like the Coconut Creek one, 2 in Davie, and then the Plantation is not going to come for a couple of years. So it sounds like currently just a couple, right? Just 3.
Yep, I think just 3.
Okay. And then I have another question coming in. This is from Mark Ellis, and basically saying, I was recently asked this question but didn't know the answer. Does the freestanding ED have to provide the same service levels as the main campus hospital, i.e. attesting to STEMI, stroke, and trauma centers, etc.?
Yep, absolutely. Remember, they have to supply just like any other ER, just like we said, just like any other community ER. So, and Dr. Paley was making a good point about stroke, and truthfully, one of the things, and that's worrying on EMS hat when we speak to these folks, you really want to know what medications are on board within that facility, because one of my biggest pet peeves is that we have the exact same medications that we have in our main ED, and that is including the TPAs and everything else. So, on the EMS side, that may be a conversation that you may want to have as they're opening up, their doors on what the capabilities are. And it is interesting because some of the freestandings have even talked about perhaps becoming primary stroke centers, because truthfully, our CAT scan is not, there's not a huge line waiting for people to get in there, number one. Number two, the TPA is readily available, to us there. And almost all the freestandings are right now run by qualified emergency physicians or board certified emergency physicians and so forth. So when it comes to those type of care, I mean, it's there. We've had walking STEMIs that, I've been able to get my last one. I think I've said a few times that was from my facility into the cath lab and ballooned up, or at least, stuck by 58 minutes,
Mm-hmm. Wow, that's awesome. So what I wanted to do next is I wanted to bring in Chief Downey. I'm gonna close this poll. We're just asking some polls while we're online here. But Chief Downey, I wanted to bring you in here. Chief Downey and I, over the last couple of months, because of the two freestandings in our town of Davie, I really kind of had to put our heads together. We had two really good tours of the facilities recently that were under construction, and then we really had to kind of not scramble is not the right word, but we really had to put our heads together as to what we got to do. Should we make a policy? Should we make a protocol? Chief Downey, do you want to speak about the process that you went through as an EMS chief, and also discuss the policy that we put together?
Okay. So this is new for us. We actually transport to 9 area hospitals, so we have plenty of hospitals around. But we have these 2 facilities that are going in, and we don't have any hospitals in the town of Davie, so they totally surround us. So we looked at the guys want direction on what patients to bring there, and so I'm thankful to all the departments that helped me. A lot of departments in our county helped give me some information that I put together, what I saw in all of those documents, kind of to be best practices. So that's where we came up with this policy, just trying to give the guys some type of guidance as to what patients we were going to be bringing to these new ERs.
Okay, and now that so this is the first 2 pages, and by the way, this draft policy is available on the Dropbox. I mean, and here's some exclusion criteria, and now that I'm hearing the input from everybody and so forth, and obviously this is early and new for everybody, and like Tony said, I think that we'll start slow with baby steps. But we may end up maybe as a county policy moving in a certain direction. For example, saying only alerts don't go to these places. Once we start to determine how things are looking on a case-by-case basis. So I really hope that's the case, and that we all have the same experience that Tony's had in Aventura with Sinai, with Mark, and so forth. So I want to bring in next Joe Nelson. Joe is our state medical director and also the medical director for AMR. And so, Joe, can you unmute yourself if you wouldn't mind, and then give us a few minutes of kind of a state level freestanding ED information if you have that available to you. Actually, I may have to unmute you. Okay, you're unmuted now, Joe. You can answer.
Okay. Yep. I guess everybody can hear me now.
Yes.
Just a couple points I wanted to make. First of all, the state does license freestanding EDs as any other emergency department. So from the state's point of view, they are an emergency department, period. And of course, the one thing I do want to mention a couple things, because for people who may be looking at reviewing this webinar at a later time, they may not know this. AHCA, the Agency for Healthcare Administration, regulates hospitals and the freestanding EDs, and the Department of Health EMS office regulates EMS agencies. So they actually, the scope of the regulation is actually split between the two entities. Florida does require that if a call is a 911 call, that it be transported to a an emergency department, a licensed ED, it does not allow transport, for example, to urgent care centers, which are looked at in a completely different vein. 401, Chapter 401 requires and allows the agency EMS medical director, in fact, charges them with the responsibility for creating protocol and for creating the destination criteria as to what sort of patients go to what facilities. So as we develop these protocols, we are meeting that statutory requirement. I will tell you that the protocols for transport to freestanding EDs vary greatly across the state. Some agencies don't transport anything to freestanding EDs, although I think that is the minority. Other agencies take everything with the exception of STEMIs, strokes, and traumas to freestanding EDs. Currently, the state I do not believe contemplating any regulatory changes in freestanding emergency department regulation, nor are there any changes that I know of currently being contemplated by EMS in terms of EMS regulation for, regarding transport to freestanding EDs.
Okay.
And that's what I want to say.
So, with your knowledge of what's happening in the state, how many of them are just saying only BLS versus ALS, or how many of them are saying we only just are not taking the alerts to the freestanding? Do you have a kind of a finger on the pulse of where that's?
No. Yeah, I'll say that I'll deal with the second question first. It's my impression that the vast majority of EMS agencies do not take trauma, stroke, STEMI alerts to freestanding EDs. I think that would be a rarity, although there may be some exceptions to that in, for example, the Panhandle, where you're talking about maybe up to an hour transport time if you don't go to the local freestanding ED. I do think they make some exceptions there, but the vast majority don't transport those high acuity patients to freestanding EDs. As to how many of them distinguish between BLS and ALS, I really don't know. I think that this topic in general would be a very good topic for the Florida Association of EMS Medical Directors to undertake maybe some information gathering on.
Right, and so let me ask another question then that would be beneficial moving forward. Is there, and maybe Tony, you can answer this one. Is there anyone, or is your committee collecting outcome data or kind of the really case by case data rather than just the kind of the big overview percentages that you showed us earlier, so we can start to evaluate what the outcomes are from these facilities, so that moving forward we can kind of modify our protocols if we have to, either one way or the other.
Yeah, Peter, we have which I didn't share because it's kind of committee paperwork. We really have a full sort of assessment of each facility, including how many docs are on there, what times, how many nurses, the staffing pattern, the CAT scans, the ultrasounds, when are they available, et cetera, et cetera. And with that, we have a whole benchmarking process that we're going through now, because exactly for this question, because I always said, listen, sometime along the way, people are going to ask, what are you guys doing? Are you doing it better? Are you doing it worse? And it's important for us as a group for the freestandings, to have that data available. So as we speak now, we're putting some benchmarking together and trying to figure out, or at least, putting some of that data together. For instance, the usual stuff. I mean, the easy stuff is easy, and that is, the aspirin, the antibiotics, all the core measures, and then we're also going to move along from there. in reference to how long does it take to get people up into their room once admitted, et cetera, just like the ER database. So we are working on that, and then I'll share that as soon as we get that compiled.
Well, yeah, well, I mean, I think that would be fantastic if there was not a long laundry list of things, but if, as a medical director, and I'm speaking for myself now, if as a medical director, I was emailed, let's say once a month, data about the patients that I transported into that hospital, or just overall data on how that freestanding ED is functioning. I think it would really, that transparency, just like with any other etiology, stroke, trauma, whatever you want to call it, would really help kind of maybe bridge the gap between EMS and the freestanding, and it would give them really a good working relationship. Does anybody have a comment on that? Tony, you first, and maybe any of the other folks. I know there's some administrators on the line here, but it would really generate.
I think Peter, it gives us a good opportunity now here in Broward County, being that we've yet to have any of these facilities come on board. Us as EMS folks, that may be part of our initial discussion. Listen, we love to gather some of this stuff together so we can share that. And in fact, one of my thoughts that I had in the past was, we can share some outcomes together. As an organization, both on the EMS side and the hospital side, on what we're doing from freestanding. But clearly, the initial discussion on your transports and all that, you may say, hey, we'd love to get some of that data. Would you be, willing to share X, Y, Z? And I think maybe we should think about that as we go talking to, to the folks that are opening up the freestandings. Because in all honesty, they are going to want to do as much as they can for us to have that relationship.
Correct. Yeah, I think that partnership would be fantastic. Speaking of the partnership, there was a question that are there protocols that the medical directors should know about that the freestanding EDs use to get their patients to the main hospital? Are you familiar, or how does your freestanding do it in Aventura as far as?
I think that's very important, because I think and again, it's all about your initial conversation and the relationship and the partnership you're going to have with that facility, because I think it's very important for us to know on the EMS side, well, if you have a STEMI, what is your plan to go there? If they say, well, we have our own private ambulance here, an ALS ambulance here that's 24/7. Okay, if your ALS ambulance right now is transporting a COPD, a CHF person, and so forth, what backup do you have for a STEMI that walks in, 10 minutes after they leave your facility? Do you have a second transport available to you? Or do you have to call someone, or you're depending on calling 911 and those type of things? I think it's important for us to really right off the bat know what's their plan for those type of transports from their facility. Clearly, the regular sort of run-of-the-mill admissions, should not be, I believe, should not be calling the 911. Now, remember, the question is, do some of the folks that are interested in intra-facility transports, do you want to get into that conversation with them and offer that services, to the facility as well? I mean, that's a whole other discussion.
Right, and so let me bring in Cheryl. Cheryl, are you okay if I bring you in here regarding the interfacility and your take on this process? Is it going to differ at all? It doesn't sound like it should.
Can you hear me, sir, first?
Yes, we can hear you.
Okay, wonderful. I'm very glad that Dr. Gandia addressed that issue, because that was one of my concerns, is how you're going to handle that secondary call. I'm very glad that most of the agencies, or most of these freestanding centers, do have an agreement in place with a private entity to provide those services, because they can station a unit there for the entire length of time that the center is open. I do know that within some of those agreements that they've identified they're going to have at minimum one unit ready to go immediately, and a second unit as soon as they get a patient in that they feel that they're going to transport out, and they start that conversation, that there'll be a call put into the secondary unit to respond. That's okay in Miami-Dade County and in Palm Beach County. Unfortunately, in Broward, we do not allow our private providers to respond in a code 3 mode to any facility, with the exception of the pediatric facilities in the county, when they're going to pick up a team, an additional team, or they're going and they have the team on board and going to another hospital to pick them up. So that's the only concern that I have in that is they believe that they're going to have a unit going code 3 to that freestanding ED to put coverage in. So that's a little discussion we have to remind the providers that you can't do that here in Broward.
Mm-hmm.
But Dr. Gandia was right on target, and I do know that those agreements are in place, and I do know they work. Now, if any other municipal provider that we have in our community that wants to do those transfers or enter into an agreement, they can do so. But I don't know if any of you are going, or any of the providers are going to do that, because you're going to have to station a unit there for the 24/7 that this facility will be open. Or maybe you'll work in conjunction with whoever the private provider is, which means and I'm just going to use Margate. I'm sorry if you're on the line, but just to let you know, I'm using you as an example. If the new center that opens up at FMC, they have American on board as their contracted provider. They have to transport someone out, and they need to transport them to another facility, and they need somebody to come in and take their place. Are they going to be willing, Margate going to be willing to go in and use their inter-facility transport certificate to put a truck there and keep it at that station or that hospital until a private provider can come online? So those are some questions you may want to discuss amongst yourself and your powers that be. But
Right. Well,
I don't see too much of another issue with it except in those dual cases.
right. Well,
Yeah,
let me
Go
go ahead.
Peter, I'm sorry.
Go ahead, Tony.
No, as I said, truthfully, our responsibility as a 911 service is that, and you got to remember, how many times is that going to really occur? I mean, truthfully, I've had probably less than 8, actually it was 8 last year walk-in STEMIs, and they were able to go, etc. But the question is, how often at all if you're going to get a second such problem that you don't have someone there that the privates have been contracted to? So, wearing our EMS 911 hat, listen, if there is a patient that really needs that type of care immediately, then the 911 service should probably be called and get those patients out of there, just like any other community hospital that doesn't have, the STEMI or the stroke and all that. I mean, many times they will call the 911 service, to get those to the proper facility.
Gotcha. All right. Go
Excuse me,
ahead.
one more comment in reference to that. That's only if they meet the appropriate criteria, Dr. Gandia, that we have in place in Broward for the emergency 911 calls.
Right.
But I have to agree. I don't think you're going to have that many that are double banged. I did a couple checks with my counterpart in Palm Beach County yesterday on another issue, and that was one of the issues I asked was if she's aware of any times that they have a duplicate of calls, and she said it's very rarely that it happens, and they have 2 such facilities up in their area.
Yeah.
Okay, very good. I appreciate that, Tony and Cheryl. I have one last question for the group, just something that I'm thinking about, something that Palm Beach currently does do, which is if they're going to transport a patient, so they're, imagine they pick up a patient, they're in the back of the truck, they're going to a hospital or freestanding. If they do go to a freestanding, they have the patient sign a waiver that says, you have to be aware that this is not the full service hospital and so forth. Is that something that we should think about? Tony, what do you think?
I think Miami-Dade was doing that also initially. I'm not quite sure if they do it anymore. I think part of the verbiage was that if you're getting admitted to the hospital, this may not be your final destination, that type of verbiage. But, truthfully, I don't know. I don't see that that's necessary. But again, because we don't do that with other community-based emergency departments. So, I don't know. I really have a sort of 50-50 discussion with that, because the question is, do you need to make the patient aware that this is not your final destination if you need to be admitted to the hospital?
And Mark Ellis just typed in that they did that initially, but no longer do that because they found it unnecessary.
Yeah.
I think where that question was coming from was, imagine a patient goes to a freestanding and then has to be transferred out, and they are getting the additional billing, which question we didn't really get answered today. And I think that's really the question: is the patient going to come back to EMS chief and say, "Hey, what is this? What is this extra bill that I got in the mail?" So I think if we can clarify those couple of questions, then maybe we won't need that information. So all right, so I'm gonna see if any. Oh, here we go. Irfan Mirza says the ambulance would bill the hospital, and if the patient is transferred from the freestanding or outside. So you know what? I'm actually going to bring you in, and so you can make the comment yourself, Mr. Mirza. Go ahead. You're unmuted.
Yeah, hi. Yeah. So the hospital basically pick up the bill from the ambulance company if the patient was transferred from the offsite to back to the main hospital.
So it is truly only a single bill, but that's if it's the hospital where that was affiliated with the freestanding. What if it's not an affiliated hospital?
I'm not sure in that case. It would be if it's the affiliated hospital.
Gotcha. Okay. Awesome.
Say Peter.
Yes, Wayne, go ahead.
Actually, this isn't my original question, but I thought that the question originally had to do with another ER bill. And so that, let's say that the patient has an ER visit at the freestanding ED, and then goes to another emergency department, which commonly I would think that would be a common intake, or a solution.
That's a good point.
And then do they bill again for another emergency visit? And frankly, would it stand?
No, that wouldn't be the case. If the patient's being admitted, then the ER visit is just incidental to the admission, so they wouldn't get two bills.
What if it's ER to ER?
It'd still be. Remember, the way these things are set up, it's the department of the hospital, so it's as if the hospital is billing.
But I guess I believe I understand what you're saying. I believe you're talking about the sister hospital, but let's say it wasn't the sister hospital, and I think it'd be rare that that it didn't go to the ER as another ER visit for reassessment, blah blah blah.
Let me
the pediatric ones would be the ones at stake here, right? Because they're typically going to go to the pediatric hospital, which are not affiliated.
Right. Because remember, almost all they get folks that are being admitted to your hospital. They get all the admitting stuff right there at the freestanding. I mean, all that stuff is done right from there, and the majority of them really go directly to the admitted room from that ER. So basically, we say, hey, my usual note is, hey, just think that we have a 12-mile corridor, from the other ER, and really you go straight up to your room. So that won't be a second billing. The question is, just like Peter said, I mean, we do transfer folks to Joe D for the pediatric care, and many times, they go and get reevaluated in that ER, and then I would assume there's a second ER bill from that ER, just like any other specialty bill.
Does anybody have the answer to that one? I mean, Wayne, I think you're right on that one, right?
I'm pretty sure, and that's what I would think. I'm not sure that should be the driving force, but it's just an item.
Okay.
I have one question. Can I?
Go ahead.
Get through? My question really was, Tony, does anybody have? Let's see. I'm trying to think. Provider demographics, and so my question essentially is, how many are the freestanding EDs staff more likely or not with board-certified ER docs? I think the idea that, people wanting to wind down the senior docs, that's a good thing and a bad thing, So I'm not sure, but I'm just sort of curious. I would imagine the contracts with the hospitals, if the contract requires, board-certified ER docs in the ED, in the main hospital, I assume that they would do that, but I don't know what the demographics are. And then a corollary to that question is, are there any freestanding EDs that are using mid-level providers?
Yeah, I can answer both. Firstly, remember, and truthfully, give you my experience from the folks over at Sinai. We have residents floating around, so they're not very happy coming to the ED where they kind of have to work a little bit harder, see patients on their own and all that. With that being said, my initial, not say argument, my point was very strongly stated that, the folks that come over, I think someone alluded to earlier, the fact that, we don't really have the backup there. We can't call quickly anesthesia. We can't call surgery, etc. So really, most of the folks that are doing the ERs are still the more seasoned folks, because again, they're pretty much there on their own, and they have to take care of all those problems and issues, especially any critical care patients that come in need to be taken care of appropriately. So really, and in fact, the ACEP has a sort of an information paper from 2013, and really they pretty much say staffed by appropriately qualified emergency physician. Our group defines that almost all, I would say almost 100% are emergency qualified emergency physician plus board certified emergency physicians as well. Mid-level providers, yes, almost everyone is using mid-level providers because they find very quickly that, because what happens is the administrative folks thinks, well, we'll see X amount of people, and within a very short time they're seeing twice as much. So we do have almost all use a mid-level provider. They're usually that 11 to 11, 12 to 12 time, etc. So they are there as mid-level providers as well.
Okay, excellent. Wayne, was that good?
Yes, thanks.
Awesome. All right. Well, it's a few minutes past 5, so I know we could probably go on for half an hour more, but I know we all have to go. But I wanted to again thank everybody. This is I learned so much on these, which is really kind of selfishly why I do these, and I think that I'm so appreciative of everyone who came on today. All the GBEMDA medical directors, you guys are amazing, and this makes it all worth it for all of us, and for all the administrators who came on today. Thank you guys as well. This recording will be available on our website, on the GBEMDA website. The shared folder will be available. You'll get an email with access to that. And again, thank you guys all. And Tony, thank you. Big thank you to you for your preparation and really educating us moving forward.